online, and I think we can start. We've got a lot of material to cover. I'd just like to start by welcoming everybody. John Lloyd, you're our program director par excellence. And I think maybe you could just give us a little bit of a update. What's happening with respect to resident issues, especially as it relates to the Royal College exams, urgency on call, deployment, and any other factors that you think are important.
So thank you, Alan. I just want to welcome everyone to what is the new face of ophthalmic education here under the era of COVID. And thanks to you and M&D for pioneering the use of this to deliver our education. Now, just before I talk about what you mentioned, I just want to say we do realize that today is a day of religious significance for many, but we elected to keep the rounds going because we wanted to keep the momentum of this online education rolling. And we are looking at means of archiving the content for those who are unable to join us today. And we'll keep everyone apprised as to when we settle on a solution for that. So yes, I want to give a shout out to our residents who are on the front lines during this crisis. And some of our PGY1 residents have already been redeployed from various fields to general internal medicine. And just got the update this morning that at UofT, about 380 residents across various fields have also been redeployed to various medical areas. Now, our PGY 2 to 5 residents remain on service, and they are taking 24-hour call shifts. And so far, the system recognizes that ophthalmologists are rather unique in terms of their skill set and not easily replaced. So at this point, we're not expecting our more senior level residents to be redeployed. And finally, just a brief mention about the Royal College certification exams. This has been a source of angst amongst our PGY 5 residents. So these have been postponed until at least September. And the latest update is that there will no longer be any oral component to the exams. It will just be a written one. All the PG5 residents across the country will get licensed from their provincial certifying bodies, but they must complete their certification examination before the end of the calendar year. Now that's all I wanted to say. I'm going to pass the torch to either M&D or Alan, whoever wants to speak next.
I'd like to wish everybody, just echo John's words. Thank you, John. I'd like to just echo John's words and wish everyone a happy Passover and Good Friday. I'd like to begin. We've got a record I think for attendance at rounds. We so far have 281 participants. I'd like to welcome everybody. I'd like to introduce our guest speakers, and I'll start with Dr. Susan Schweines, who's on this line, and she is the Associate Dean of Continuing Professional Development for the Faculty of Medicine at the University of Toronto. I've introduced John as our Program Director. Dr. Sharif El-Dafraoui, he holds the Nanji Family Chair in Ophthalmology and Vision Sciences, and is Professor and Chair of the Department of Ophthalmology at the University of Toronto. Grant Slamovic is an emergency doctor who's going to be representing emergency and speak a little bit about the ICU as well. Dr. Slamovic trained in emergency medicine in the Bronx, New York, which is the eye of the storm at present. He completed his FRCP at the University of Toronto and has been on staff at UHN ever since. He is the emergency department liaison for stroke care, and his main interest is ophthalmology and environmental emergencies. I'm going to introduce Dr. Sharkawi. He's currently on CTV as their consultant, but will be parachuting in shortly, and I'll introduce him when he arrives. I'll introduce someone who really needs no introduction and has been driving a lot of this in a wonderful way. Amandeep Rai, who's the Associate Program Director. We all know Yvonne Baez, Professor, Department of Ophthalmology, Co-Director of the Glaucoma Unit, President and Board Member of the Canadian Ophthalmological Society. Radha Kohli, who's going to represent Medical Retina. She is currently our Vice Chair of Faculty Development, Equity, Diversity and Inclusion, and Global Health. Rob Devigné, Professor of Ophthalmology and Vision Sciences, will be speaking to Surgical Retina. He is the ophthalmologist and Chief and Director of Retinal Services and currently holds the Karen and William Barnett Chair in Ophthalmology. and someone who is, we all know, and just recently over the past half hour, was kind enough to zoom in to our rounds and will tell us a little bit about what's going on at the other end of the world. Dr. Wai Ching Lam. It's currently 12 midnight in Hong Kong, and he is the professor of the University of Hong Kong, Chief of Service of Hong Kong at Queen Mary Hospital and Hong Kong University and Shenzhen Hospital in China. I think at this point, I'd also like to give a shout out to Sandra Gochi, who's been really fantastic in making sure our infrastructure is up and running and has been working weekdays and weekends. Sandra, could we launch the poll for the demographics at this point?
Yes, actually, I've got the poll, so I'm going to do that now here. Yes.
Could we launch that?
Absolutely.
So I'm going to ask everybody to obviously fill in, tick the appropriate box, and submit.
So we'll give it a few seconds for the polls, but we would encourage everyone to vote as quick as they can. We're going to limit the polls to about 20 seconds or so, and I'll share the results here.
And well, okay. So just over half are ophthalmologists, 23% residents, and those are the largest two demographics. We do have some optometrists, and welcome. I do want to mention, can we get a breakdown of where people are from?
Yes, that poll is coming up right now.
While we're waiting for that, I want to mention that our Friday grand rounds during the pandemic will be going every week, Friday, 12 noon to 1:15 p.m., and you're all welcome to Zoom in. While we're waiting,
all right, we've got about 80%.
Results, I'll mention
we've got about 80%
that,
results there, so I'll share that.
Okay, so we're looking at the majority coming from the GTA, 23% from Ontario, across Canada, 25%, South America, 1%. We're going out to Africa and Asia. So quite a diverse group that we have here. I want to mention that these rounds are accredited for CME Royal College credits. We asked everybody to zoom in with their authenticated email account. And this is both a security measure, and also we will be collecting this data so that you can receive your CME credits. We will be recording and archiving grand rounds. We will be taking some questions after each talk, but we will be leaving the majority of questions. We'll be saving some time at the end of these rounds for Q&A. So without any further ado, I'd like to introduce our chair of the Department of Ophthalmology, Dr. Sharif El-Dafraoui. Sharif?
Well, thank you very much, Alan. And I'd like to welcome everyone to our virtual grand rounds. As both John and Alan have mentioned, this is Good Friday and Passover, and so thank you for joining us on these very important days. And I really hope that everyone is staying well and healthy and safe and not going too stir crazy with this crisis. I wanted to just update people on a few things that are happening in the department. With respect to our hospitals and our hospital chiefs, they've worked very hard to reduce the clinics and the ORs to only emergencies and ensure appropriate PPEs and minimize the risk of cross-contamination of staff and residents. KEI, where a lot of our elective surgery happens, closed its surgical doors on March 17th. And realistically, I don't anticipate elective surgery opening up again at KEI until late June, but we'll keep the department posted with respect to that. I anticipate, as we all do, that we'll be facing a large backlog of surgical cases, and it's especially so with semi-urgent cases like glaucoma cases that aren't emergent enough to be done now. And so we really need to look at options on how we can expand our surgical days once we reopen. And so we're looking at that and how we can do more cases once we get things going back up to usual. When this whole crisis was first upon us, we had canceled all our teaching sessions and rounds because they were in-person gatherings. But we've quickly realized, and I think we've all around the globe, we've realized that we can carry out this sort of sessions virtually. And so we've reinstated a lot of our sessions, and I'd be remiss if I didn't thank our Associate Program Director, Amandeep Ray, and our Program Director, John Lloyd, and of course our Vice Chair, Education, Alan Slomovic, for the amazing work they're doing in organizing all these sessions. Matt Schlenker is our Director of our Research Day, and he's looking to have our Research Day using this platform as well. And but what we'll do is break up our Research Day into 4 weekly sessions, and there'll be more announcements on this later. And these Research Day Zoom sessions will take place in May. I also just wanted to say a couple of words about ACUPO, who has been corresponding regularly. ACUPO is the Association of Canadian University Professors of Ophthalmology, and it's really the chairs of all the departments at the academic centers across the country. And we've been talking quite regularly to ensure that we're on the same page with respect to all academic activity. Kareem Damji in Edmonton is the president of that group. And we've also been liaisoning with the COS and the subspecialty societies to ensure that there's standardized and uniform quality care occurring across the country. And of course, our department here at the University of Toronto has been in close contact with the deanery in order to ensure that we're on the same page with respect to what we're doing with our medical students, our fellows, and our residents. And so that's really what's happening during this crisis. I thank you once again for joining us for these rounds, and I hope you continue to stay healthy and safe. And I'll turn it back over to you, Alan. Thank you.
Thank you, Sharif. I think there's time for maybe one question or two before we will go to Wai-Ching Lam. But appropriately, you mentioned that hopefully we'll be opening up in June. You know, there's a lot of speculation about what opening up is going to look like. Before we go to Wai-Ching, who is actually opening up in China, do you have any idea of what that's going to look like?
As far as the surgical space?
Time, surgical space, being able to sort of catch up on our backlog of patients who are waiting.
Yes, I think we really have to strategize to ensure that we can do something about these backlogs. So once we open, we're looking at several strategies, and we really are dependent on anesthesia for these strategies. One of the ideas is looking at 12-hour days where we can have 2 surgeons operating on the same day, 6 hours each, which would expand our time significantly. Also, we can look at operating on Saturdays to expand the time as well. So we're exploring all those, and we'll see which is going to work best for us once we get going.
Thank you, Sharif, and thank you for leading that charge. I think that's going to be an important element when we start coming out of this. Maybe, Wai-Ching, can you tell us a little bit more about what's happening in your end of the world? What's it look like? What did it look like going into this? And what does it look like now? What kind of measures are you using trying to open up the system?
Well, thank you, Alan. And first of all, I want to congratulate the organizations of this grand round, because I think this is very useful and very informative. And so thank you for the opportunity to share my experience in Hong Kong. I think we all have this information.
Wai Ching, we can't hear you. You're going to have to lean in closer.
Okay, is it better now?
Yes.
So I was just thanking the opportunity to share the Hong Kong experience that I'm going through. With the current situation, we have really a lot of information overload. I get 20 to 30 email on the topic of COVID every day. And there's always the separation between facts and false information. I think the grand round like this will help to disseminate proper information from the right source, and the COS and the CRS and the different associations are doing the same. In Hong Kong now, what's interesting is that at the beginning, we started this back in end of January. So you guys are 2 months behind us. And in January, we didn't have a total shutdown. And we actually has a stepwise approach because at the time, it was only import case. We do not have any community transmissions. And talking about the, in the hospital, we were doing the usual screening with temperature and questionnaire at the door. And most of the people are quite aware the self-discipline and the seriousness of this epidemic at the time. And because we have the experience of SARS in Hong Kong, and so people take things very seriously. So right away, people were already buying face masks and being very cautious about the approach. And the hospital instructed us that we have to reduce our clinical service, the outpatient clinic, by about 50%, and essentially stop all the general anesthesia surgery except the trauma, cancer, and organ transplant. And then all the cases are mostly done in local anesthesia. We still maintain about 30% of our usual surgical volumes. So we didn't totally shut down. So different than what the situation now in Toronto. But I think the problem is in Toronto, you have community transmissions now. At the time, we didn't have. And then we were able to preserve most of our injection patients' volumes. And now, in middle of March, we have this second wave surged. And both Hong Kong and Singapore are experiencing the same. And they are imported cases, which means they're people who are coming back to the city from the different part of the world, from UK, from North America, and that created a sudden surge in both Hong Kong and Singapore. And for that matter, the government for both places has implemented much more stricter restrictions. And until now, these cinema, beauty parlor, gyms were partially open, but now it's all shut down. And as far as the medical part for ophthalmology and the rest of the hospital, we were still maintaining the same service as the beginning, because at the time when we were preparing for this, the intention was actually planned well ahead in terms of the ICU beds, the isolation ward, to anticipate the volume. So far we're still managing without any overburden of the system. So for that reason, we were able to still maintain about 50% of the clinical service. We were hoping that we were able to increase before the second surge, but then realizing that it will not be possible. Surgery-wise, still the same. And we have a committee led by myself and the subspecialty leaders to decide what are the urgent cases that need to be done for that, especially for the general anesthesia case. And in terms of the precaution that's being done at the in ophthalmology, there has been a fair bit of discussion for the need for N95 versus surgical face masks. And for us, the N95 only reserved for the frontline people who are dealing with COVID positive patients or confirmed cases. And for the ophthalmology, if the patients are not having temperature or the questionnaire put them at low risk, and they will be managed with the staff wearing just face mask, and there's a barrier put on the slit lamp, and the patients and their family will also wear face masks, surgical face mask during the time. N95 is not used. If the patient are coming from a place with high risk, and then it will be shuffled into an isolation room, the staff there will wear full protection gear, full PPE. So they will wear face shield, N95, and the protective outer coating. And likewise, we stopped the air puff intraocular measurement from the very beginning. And if the patient needs intraocular pressure measure, they use eye care or a Goldman tonometry. And in the operating room, the outpatient, the local anesthesia are still going on. And if that happens, the patient have a nasal prong, wear a surgical face mask with the tape across the top of the face mask, and then the patient will be draped the usual fashion. The surgeon wears the usual surgical kind of face mask and the scrubs and the gown, and no additional protections or gear was used. Oculoplastic was also canceled at the very beginning because they do have more risk of aerosol spread, especially when they do lacrimal cases. For the general anesthesia cases, we actually leave the room. Only the anesthesia team stays in the room during the intubations and extubations. And all the other surgical staff, the nurses, scrub nurses and circulator will step out of the room, and until that procedure, the high-risk procedure is completed, then we return to the room. So just going back to what was discussed earlier about letting up, you have to be aware of the possibility that things will surge again, even though when things are improving, because you still, unless you still have a total shutdown for restricting traveling from the different provinces and from different cities and countries, there's still the possibility of the cases will resurge again. And the social distancing, checking the contact cases to try to find all the contaminated individual or infected individuals are paramount in trying to limit the cases. And when you need to restart, people have to restart slowly, and making sure that all the necessary precaution has to take place to minimize cases to cause resurgence of the infections. Being in the medical field, we are the most vulnerable, and but we also are the people that are most needed to provide the necessary care for our patients. So it is a very tight, difficult balance act. I'll stop here.
I think we have time for a question or two. Amandeep.
There's no specific questions at the time. There is a question for Hall Chu, but we'll hold off on that one for when we get to either Brant or Abdu, who is now on the line with us as well.
Abdu's joined us, and I'll introduce him when we get to his talk. I think, Wai Ching, thank you so much for updating us on what's happening across the world on the other end. Are you seeing the light at the end of the tunnel? I mean, you're opening them up, but is there a light? What does life look like on the streets? What does life look like in the hospital? Is your OR operational 100% now that you're opening up, or is it 25, 50, 75%?
Actually, we have not opened up. We're still running at about 30% of our usual capacity. That's the same as from the beginning. and our outpatients still about 50%. I do see that's the end of the tunnel, especially with the experience with SARS. But I think this is going to be more prolonged than SARS because of the global pandemic that's happening, and also a lot of patients are asymptomatic while they still transmit the viruses. I think these combinations are making it going to last longer. So I think ultimately it's the vaccine is going to help us from having recurrent kind of resurgence of these infections.
One last question. How long have you been on lockdown, roughly?
Since mid-January.
Yeah. Okay. Thank you very much, Wai-Ching. That was really very interesting. Our next speaker we've introduced is Dr. Brant Slamovic, who's going to represent the emergency department, let us know what's happening there, and also a little bit about the ICU and ICU beds. Brant?
Sure. Thank you very much. I guess Amandeep will launch my
Yes,
slides.
Brent. Yeah, give me 1 second here. I'm just going to launch your slides here.
I'll just start off by saying, first of all, thank you, Alan. Thank you, Amandeep, for the invitation. As the representative from the emergency department, I can say, first of all, how much we appreciate our relationship with the ophthalmology service at UHN. It's nothing short of probably the most collegial and supportive group that we have, so thank you. So I've been asked to present sort of the landscape of the emergency department in the time of COVID. I'll preface this by saying that this is very Toronto specific, so my experience is really limited to Toronto, even though I am in touch with people all over Canada and many colleagues and dear friends in New York who are undergoing a much more difficult time than we are up here. So there's a wide practice between provincial jurisdictions and between countries that's based on experience and demographics and obviously resources which are not uniform. So it's a fluid landscape and things are changing for us day by day and sometimes hour by hour. And my slides will reflect that. Hopefully we just updated version 3 of this talk this morning. So if I can have the next slide, please. So I just want to begin with giving you just a little bit of a layout of what's happening from the emergency department perspective. Outside the clinical practice, of course, the initiatives that are being undertaken at UHN are just incredible and almost too many to name. The first one is we have international leaders in the area of simulation, which are working tirelessly and on a day-to-day basis to keep us all up to date with new skills and also designing new paradigms for treatment, specifically with what we call now protected code blues or code resuscitations, which I'll go into a little bit more detail in the next slide. But we've also been instrumental in setting up the assessment centers where COVID testing is done outside of the hospital and the emergency department. We have one of our ED staff who's undertaking this incredible project called Phone Connect, which basically links vulnerable populations with cell phones if they don't already have them. So when they leave the department, they have a free mobile phone, which allows them to remain in contact and have access with loved ones and family, but more importantly with social work providers and healthcare institutions and public health so that if testing results come back, they're connected with follow-up care. In terms of research, we have trials undergoing now with hospital care worker prophylaxis with hydroxychloroquine, and in addition, validation of cell saliva testing versus staff NP swabbing. Virtual ED visits are on the horizon. They will probably launch next week. We're also intimately involved with other stakeholders in surge planning, and I'm happy to say we've not gone into that mode yet, but as my first slide mentioned, we are preparing for the worst, but obviously hoping for the best in this case. And then another thing that we've really undertaken is a wellness initiative. As you know, this is an unprecedented time of anxiety and worry for all front of the line workers, not only just with our patients' well-being, but also with our own safety, and then of course with what we bring back home to our families. So it's been one area where we've concentrated on to make sure that we're all doing as well as we can in a time where things are different than ever before. And if I can use an analogy that's sort of going around, for us on the front lines, it feels like we're really on the beachfront waiting for the tsunami that we know is coming. We just don't know when it's happening and when or how big that wave will be when it hits us. So that's a little bit about what we're undergoing right now in the emergency department. Next slide, please. So I alluded to this previously, but this is our code resus, which is basically a new paradigm that we've undertaken in how we treat our sickest patients, those with the peri-arrest and arrest sort of scenarios. It's really just a different way of thinking of how we provide care. One, we're working now with small teams, so a small team in the room and a team outside the room. Usually it's when there's a code recess called, as many people show up as can because people just want to help. But in this case, we're trying to protect our staff and minimizing risk of spread of coronavirus to those involved. We're trying to figure out how to communicate effectively with PPE on, with teams inside and outside the rooms, how to minimize airborne generating medical procedures, those obviously with the highest risk of transmission to healthcare workers, and also standardizing medication doses so that not only is there an offload of cognitive information to the staff, but also just to standardize and make sure that treatment is optimal for all the patients. Next slide. In terms of aerosol generating procedures, this is kind of one of those areas that we're spending the most amount of time. It's also part of the bread and butter of what we do in Emerge. It's also a continuum. So intubations and extubations, non-invasive ventilation, high flow oxygenation, and nebulized medications is what we do every day. We're doing those very differently these days. We're avoiding them if we can at all. And if we can't, we use very precious resources of negative pressure isolation. CPR remains an interesting one. It's one for debate. And again, there's different approaches in different areas, but we don't actually know which part of the CPR process aerosolizes the virus. So we're trying to take things that are usually droplet and prevent them from being aerosolized in the first place. But that's something, again, this is based on science, but the science is almost all based on simulation as opposed to real cases. Next slide. In terms of who we're testing, the Ministry of Health has laid out guidelines for testing basically all patients with mild symptoms and those that are at high risk for transmission to large groups. So symptoms of cough and sore throat and headache and myalgias and the usual viral stuff. So those who are working in high risk settings, those who reside in vulnerable settings, so shelters and homeless group homes and respite centers and correctional facilities, and of course those sent to the Emerge by Public Health. All ED patients with acute symptoms of fever and respiratory infections and who have clinically significant symptoms, basically those that are affecting activities of daily living, get testing, and all patients with symptoms of fever and respiratory infections that are being admitted to the hospital are obviously being tested. But I can say that this is, again, it's a fluid paradigm. Expansion of criteria is happening all the time. So now we're talking about screening all elderly and all indigenous populations who we know are at higher risk. And of course, the clinical judgment rules all cases here. So on the front lines, the restrictions really aren't in place. And if you feel that clinically the wisest choice is to test people, then we're testing them in real time. Next slide. In terms of PPE, I know there was a couple of questions for the panel. Again, we're in a state here in Toronto of conservation of PPE. It's a dynamic situation. Currently, this is the recommendation by UHN, and I'll just summarize this infographic very simply, that if you are performing any of the previously described aerosolized procedures, an N95 mask is the only time that we're using this level of care. As of yesterday, every patient who comes into the Emerge is under droplet precautions and contact precautions. So if they're not N95, so COVID positive or patients undergoing aerosolized procedures, then we're using things like face shields with surgical masks and of course, level 2 gowns and gloves. We have other plans in the pipeline. So using recently expired PPE or PPE that's been donated graciously from other sources, namely being the community and other industries. And as a last resort only, we are currently working with Health Canada to figure out a way to sterilize previously used N95 masks. But again, we're not fortunately in that state. As of this week, we know that we have about 30 days of supply of N95s and full PPE at UHN, and we're continuing to receive shipments from all over the world, including China as of this week. Next slide, please. One thing I should say about the PPE is that there's been a statement from the CEO of UHN saying that UHN providers will not be asked to work without adequate and safe PPE, which is a big reassurance to all of us in the Emerge. I can tell you that on the order of hundreds of messages a day on our internal WhatsApp group are exchanged on ways around PPE, where to allocate and find sources of shields, everything from Canadian Tire to Home Depot. So there's an immense amount of worry and an immense amount of work being done to get to a situation where we're never working, where we feel unsafe to take care of people. As far as eye cases in the ER with COVID, we're actually not seeing a whole lot. To be honest, our overall numbers of non-acute patients are actually remarkably down in the emerge. So the flow through fast track and urgent care is extremely low. And I don't think as of yesterday, we have a single defined case of COVID that's presenting as a primary ophthalmological presentation. So no conjunctivitis and blepharitis that we're seeing as first presenting cases. We are using these shields on our slit lamps, courtesy of Dr. Alan Slamovic, who arranged for them to be manufactured and distributed. But again, as of yesterday, we are using droplet precaution and contact precaution for all patients. So gowns and gloves and a procedure mask with a shield in place. Next slide. I'll just end up real quickly with a couple of stats about ICU. So this is the data as of today from Ontario ICUs. And what we've seen over the last month is a slow increase in the number of ICU beds being occupied by positive and suspected COVID patients. Again, this is the number, and I'm sure Abdu will talk about this a bit more since this is really his ballpark of expertise. But currently what we're thinking is the ICU number is the number to gauge where we're headed with the disease, as testing seems to be fluctuating variably. But as of today, it's the first time we've seen a slight drop in the number of positive cases in the ICUs in Canada, sorry, in Ontario. At UHN, we currently have 24 admitted ICU patients of a total of 39 who are COVID positive. And the vast majority of these are coming as transfers from the community, so not primary ED visits at UHN. Next slide. And this is just a slide to show you the critical bed occupancy rates within Ontario. So I think most ICUs in Ontario are operating anywhere between 50 and 70% of capacity as compared to last year, which is highly reassuring. Toronto, as of yesterday, had a 69% ICU bed capacity. And if we were to go into our extended ICU capacity, which we have not done yet, we would be at around 55%. So I think it's fair to say that we can be cautiously optimistic with the trending numbers. I think our colleagues in overseas in Hong Kong and China are heeding a fair warning that we should be worried about or potentially for a second wave. But I think for now, we could say that, at least I'm happy to say that testing and self-isolation and distancing and the shutdown of non-essentials has been working, although we must need to continue it and to be sort of perpetuating the message of social distancing and really staying home as much as you can.
Great, thank you. Couple questions for you, Brand, from the chat here. Something you've sort of alluded to, but the idea that the number of tests is below testing capacity per day, is there any plan to relax the testing criteria?
We're hearing word from the Ministry of Health, and I guess Abdu may have his foot on the sort of the pedal more than I do in this case, but we're hearing every day that there's talk of the ministry loosening testing. I know that at UHN, our assessment center is virtually empty most of the time. But again, I think the people on the front lines in the ED itself are screening much more liberally than we were even a week ago. And we're sort of taking the Ministry of Health as guidelines, but our clinical practice and gestalt and what we're seeing in front of us is really dictating who we decide to swab and not swab.
Okay.
I want to thank both you and Abdu for being really up there at the front line. I think you guys are really doing an amazing job.
Thank you. Any other questions? I'll stick around into the end in case something else comes up, but I'm happy to answer anything else.
Yeah, there's a number of questions, but I think what we're going to do is we're going to try to hold them for the end. There is a Q&A where we'll go back through the chat and try to address many of them. But in the interest of time, I think we will move on to the next speaker. So Alan, I'll give it back to you.
Thank you, Amandeep. So I'd like to take this opportunity to introduce our next speaker, Dr. Abdu Sharkawi, as our infectious disease expert. Dr. Sharkawi completed his medical training at the University of Alberta and did an internal medicine residency at the University of Toronto. He completed his infectious disease fellowship at the University of British Columbia and has worked at UBC, Queen's University, followed by University of Toronto since 2007. His interests include invasive bacterial infections, HIV, and multi-resistant organisms, and he's been a constant presence on CTV talking about the pandemic. So, Abdu, thank you very much for joining us.
So, Abdu, I'm going to put up your slides. So whenever you want me to forward to the next slide, please do let me know. And you are
Okay,
unmuted there.
Am I unmuted? Can
Yes, we can hear
everyone
you. We
hear
can
me?
see you. Yes.
Okay, great.
Thanks for being
First of
here,
all,
and give
thanks
me a
for
second
the
to get your slides.
invitation. And it's ironic that I'm disconnected from my patients, but I'm always sort of connected to some sort of headset or wire these days. I'd like this to be hopefully as practical as possible for you as ophthalmologists, and to give you a little bit of a sense as to what sort of containment strategies and infection control strategies we're using. And also to give you some practical tips on what you should be doing when you're assessing patients in your clinics and how to mitigate risk. Next slide. So one of the major concerns that has been brought up by a lot of my colleagues is what's the real risk of infection that can be transmitted through tears? And although the data is somewhat limited, there has been clear evidence that there is COVID-19 that can be detected in tears and conjunctival secretions. And this is kind of problematic because, as many of you know, the type of follicular conjunctivitis that presents as part of COVID may be completely indistinguishable from that that's caused by a lot of other benign viral etiologies. So it really behooves the ophthalmologist to have a very high index of suspicion when they're seeing somebody with conjunctivitis that they may be dealing with COVID-19. It is an aerosol type of transmission that's occurring. So if you're concerned and you're assessing patient, you should ideally be wearing an N95 mask and, if possible, a face shield as well while you're examining them. The other thing to be aware of is that the duration of viral shedding can actually be quite prolonged. In some of the bigger case studies, the average has been about 20 days, but in some, it's actually exceeded more than a month. So that really gives us pause to recognize that somebody who may not even be symptomatic anymore, but has a history of contact with a COVID positive patient or a syndrome that sounded like COVID positive, even within the last 30 days, you have to take some care when managing them. Now, if you're doing basic assessments like tonometry or fundoscopy or a slit lamp exam on a patient who's not symptomatic and doesn't have a conjunctival issue, a routine surgical mask is probably more than adequate for these purposes. In terms of the highest risk, it probably involves anything that involves irrigation of the nasolacrimal duct, because that's essentially part of the respiratory tract. And so for any procedures of that nature, you're going to want to use an N95 mask. Ideally, you should use goggles as well. And it's to your discretion whether you want to use a face shield as well. If you can do it and it's not technically challenging, but I recommend using it whenever you can. Next slide, please. So, and this is in keeping with the recent UofT guidelines that many of you may be familiar with from the Canadian Society of Oculoplastic Surgery, so that any sort of irrigation manipulation of the lacrimal system is defined as an aerosol generating procedure, and that you have to apply strict PPE while doing this. Next slide, please. So what about the sort of common sense practices that you would want to apply for patients that still have to come to your clinics? Obviously, there's a lot we can do virtually, but there's only so much you can do, obviously, when you have to examine people through fundoscopic techniques, etc. So the key is that patients need to be screened prior to even entering the waiting room. And the routine questions are obviously about travel, but increasingly fever, any respiratory symptoms, any contacts with a COVID-19 positive patient in the last 2 weeks. And if a patient flags positive to any of this, they should really be turned away, not allowed to enter the waiting room, and then sent to a testing center and for further follow-up with their primary care provider. It's sort of common sense, but it's important to recognize that waiting rooms should be kept as empty as possible and that strict distancing is applied. And that, of course, any patients that are even coming to the clinic should really be the most highly prioritized. If you're talking about other things that you can do to help, slit lamp barriers and breath shields have been used, but it's important to be aware that this is not a substitute for other infection control measures. So really strict attention to hand hygiene and disinfection of all equipment before and after patient assessment is important too. Another thing that, last point there that's important is even verbal interaction is important to minimize. So we have to be aware that even through speaking, if you're within 6 feet of somebody who's COVID-19 positive, there's a risk of transmission through the droplets. So ideally, you want to minimize the amount of talking that you're doing and tell the patient to do likewise during your examination. Next slide, please. So this is sort of carrying on a little bit further as to what Brent had touched on earlier with respect to our critical care bed capacity. And this is a few days old, but the numbers haven't changed all that much. This is Ontario-wide. So we've ramped up our ventilator capacity and our beds. We've gone up to just over 2,100 critical care beds. That's up a fair number just in the last few weeks. And you can see that our ventilator capacity is only at about 70% right now. So I would echo the same sentiments that Brent had about being cautiously optimistic about being able to maintain things where we are now, with the caveat that, of course, we had a very rapid surge, we may not be in such a great position. Next slide. This is more related to the GTA. Specifically, we have 587 critical care beds right now, and 407 patients are in them. Those numbers have changed minimally in the last few days. And again, our ventilator capacity here sort of mirrors that with what we see province-wide at around 70%. Next slide. So it's a busy slide, but I want to apologize, and I'll just sort of highlight for you the different therapeutic options that have been explored. And it's really there in all of the details should you be interested in looking into it, but I'll unpack it for you. So one of the earliest antiviral therapies that was considered is something called remdesivir. Remdesivir, we have some experience using for Ebola, for other hemorrhagic fevers, and including other coronaviruses, such as the MERS coronavirus as well. This is made by Roche, and there are a lot of studies that are underway right now, particularly in both China and in the US. Unfortunately, the early data is not quite as promising as we once had imagined it would be. So I'm not actually holding out a lot of hope that this will be a very good standalone therapy for COVID-19, but it may serve as a useful adjunct. And I think we're going to need a lot more time to determine that. Another interesting drug that has been explored is an old HIV drug called Kaletra, which is lopinavir, ritonavir, 2 protease inhibitors. And unfortunately, we had a New England Journal study that kind of categorically shut the door on efficacy for treatment with Kaletra. However, there's important qualifications to this, because I think that the time in which this was employed in terms of the stage of the disease may not be one that we just want to limit ourselves to when we consider how effective this may be. In addition, there are still trials that are undergoing as to whether this may be useful for prophylaxis. And I'm personally somewhat hopeful that there may still be a role for prophylaxis with this drug. And we'll know more about this probably at some time in the next few weeks. The drugs that have probably received a lot more attention because they're touted as quote unquote game changers by certain heads of state are of course the anti-malarial drugs, chloroquine and hydroxychloroquine. And unfortunately, these have really not meted out with the best of evidence in terms of efficacy, in terms of both smaller scale studies and medium scale studies. There is kind of a state of equipoise right now in terms of whether there is a real benefit versus a risk. And I would really caution people as to being too optimistic and liberal with their strategies in using these drugs. Because number one, they are needed to treat patients with autoimmune conditions like lupus and rheumatoid arthritis. And we certainly don't want to deprive those patients of having those drugs. And there have been shortages already cited. The other thing is they're not benign at all. They are known to cause arrhythmias and QT prolongation, which can be fatal. And we've seen evidence of this, including in case reports of people who had taken them specifically for the point of trying to either prevent COVID-19 or early in the course of their disease thinking it would help. So the book is not closed, but we certainly need more robust data, both from a treatment and a prophylactic standpoint. Azithromycin is of course an antibiotic that has often been mentioned in the same breath as hydroxychloroquine to be used in tandem, again, for the same sort of idea, more for treatment. And I'm a bit leery of this, specifically because the combination of these two medications can lead to additive arrhythmia risk. So again, I'm not particularly confident that this is a regimen we should rely on anytime soon. Now, moving on to other things that are maybe a bit more exciting and maybe hold greater promise for us. One of them is the convalescent plasma. And this is effectively taking the plasma from people who have been confirmed as immune and have recovered from COVID-19, and then passively administering that to people who have COVID-19, and specifically those that are critically ill. There are studies that are underway right now, both in China, parts of the US, and in Europe. And right here at Toronto Western and at UHN, we're about to launch our own study. I'm a co-investigator for that, and we hope to get that started very soon. The preliminary data that we have, at least anecdotally, from China in particular, is that the results can be quite dramatic and very beneficial, where we see people actually improving very quickly, even in as little as 24 to 48 hours from ventilatory support. So I'm very excited about this. Other immunotherapies, which I think also hold some promise, include IL-6 inhibition with tocilizumab. So this is a drug that's largely used for refractory rheumatoid arthritis. And the preliminary data suggests that it has been beneficial for high-risk patients. The problem here, of course, is that it is highly immunosuppressive. So the risk of other opportunistic infections is not minimal. And we need to make sure that we're balancing immunomodulation with immune suppression. So again, I think this is a drug that will be looked at very carefully for the highest risk patients over the next few months. The last one is a drug that has been used mostly in Japan. It's called favipiravir, and this is an RNA-dependent polymerase inhibitor. Sorry, I can't speak anymore. There's some very limited evidence for this helping with other coronaviruses. We don't have much in the way of controlled data for COVID-19. We expect to have this again some point in the next 4 to 6 weeks. Why don't we move to the next slide in the interest of time?
That was all I had.
Sorry.
Yeah.
Okay, that might be it for me.
Abdu,
Yes, that's all I had for the slides. Thank you.
Fantastic.
Thanks, Alan.
Grant and Abdu, that was really, really excellent. It's so helpful to see what's happening on the front lines. And I really think you, you answered a lot of the questions that we had. One question, where are we with respect to our surge? Can anyone answer that? Are we, let's say in the GTA, I know you can't talk globally, but where are we with respect to our surge?
We're nowhere near it. This is a function of two things. One is we were seeing this sort of exponential rise in cases. We've been seeing that now for at least the last couple of weeks, where we're seeing a doubling of cases somewhere in the order of every 5 to closer to 7 days. So until we see that settling down, we don't know if we've reached our surge. The other problem is, as you've probably heard all over the news media, we have a really serious testing deficit. And I hold public health accountable for this and others for the message that we were really too restrictive in our treatment criteria. And we limited it to a very narrow subset of patients and people who had been contacts. And that's going to change. We're going to expand the testing criteria very soon to include everyone who works in the public domain, not just people who are in long-term care facilities, everyone in homeless shelters, and ideally every healthcare worker. And we'll need to come up with a reasonable protocol for the frequency of retesting of healthcare workers. There have been too many cases of healthcare workers who've become sick. We have an outbreak now at Trillium Health Partners, one of our bigger hospitals in the GTA. And this has obviously very serious ramifications for our patient care. So things are going to change, but I would say we're at least a good 3 weeks away from knowing whether we've hit that surge and whether we're reaching a peak or we still have to wait a little longer.
Thank you. Abdu, I think there's going to be a lot of questions, which in order to get the content of this rounds, most appreciated if you and Brant could wait around, maybe just also give you a little bit of a break for your voice and resume opening it up for questions in a little while. I think we're going to now move to the next part.
Sorry, I'm covering 6 sites with one dermatology PGY1. So I may have to leave relatively soon. I'm sorry.
So
Okay,
why
I
don't
can stick
we
around
take some,
probably for 15.
why don't we ask the questions of Abdu now, because I do think he's probably going to get the most questions of this panel and perhaps have the best answers. So we'll hold the other question till the end, but perhaps we can ask some of Abdu. So there's a lot of questions for you here, and I'll try to go through some of them. One question is, if we can sequence the virus so quickly, why does it take so long to create a vaccine?
Oh, it's a much more complicated process than that. I mean, sequencing the virus is just a very important but very early step in terms of making something that's going to be immunogenic and finding the right adjuvant, the right sort of conjugated protein that's going to work to elicit an immunogenic response, that's a huge challenge. So that's what's going to take the bigger part of the next few months to figure out.
Now, another question for you here is, what about pluristem as a treatment?
I didn't get that. What a
Pluristem.
pluristem?
Yeah,
Pluripotent stem cells?
I guess yes, that's probably what it is. Pluripotent stem cells, yeah.
I have really no knowledge as to any sort of formative research going on in that area. So unfortunately, I can't speak to it from an educated viewpoint.
Now, a very practical question for you. What would be your recommendation for an ophthalmology office if one of the staff members were to become COVID positive?
So anybody who's known to become COVID positive should immediately self-isolate. They should go home. They need to remain in isolation for a minimum of 2 weeks or until symptom resolution, whichever is longer.
And I guess the second part of that question was, what about the rest of the office? Should the office be closing down if one member tested positive?
So that's a good question. I guess it would depend on how much exposure and interaction they've actually had with other members of the office. I would say that if they have been in very close contact, you know, especially within 6 feet, and they've had any respiratory symptoms at all, then that may be a reason to get everybody in the office tested. If that's not the case, I think it's probably reasonable for everyone else to self-monitor. But remember that when you're in the office environment, you probably should be wearing a mask at all times, regardless. I wear a mask everywhere I go outside my office when I'm in the hospital.
Okay, thank you. I'll give you one more question here. Is there any other forms of screening in the pipeline that you can comment on?
Screening for COVID-19?
Mm-hmm.
Not really. I think what we need to recognize, though, very importantly, is that the screening tests that we're doing are not perfect, and they change very much depending on the stage of the disease. We had a case here in the Western just about a week ago where somebody was kind of unwell for about a week and a half, had tested negative in an assessment center in the community, came into Emerge, was tested in Emerge, was negative again, then deteriorated on the medical ward and had a very bad looking CT of their chest and ended up in the ICU, and their deep suction from a respiratory specimen was positive. Wow. So we really need to be very paranoid, very heightened in our sense of awareness, that if a story sounds suspicious for COVID-19, treat it like it's COVID-19 positive, and the test result be damned. Speak to somebody if you're concerned.
Abdul, I've got a question before we let you go. Hopefully you'll stay till the end, you won't get called, but if you do, what do you see the role of antibody testing as a means of getting, of opening up the system again, whether it be medical, whether it be financial, whether it be social, whatever? What's the role?
I think it's huge. This would have major benefits. I think first and foremost, for us as healthcare workers, we want to know that we're immune if we've been exposed, and that we can then freely advocate every ounce of our resources to taking care of patients. And that would sort of apply as the same logic to people looking after elderly parents, anyone who's immune compromised, people working in long-term care facilities, and the like. And ultimately, once this can be rolled out beyond just us as healthcare workers and other providers to a greater part of society, we're going to get a better idea as to whether we've reached what we call herd immunity. And then we can anticipate that if there are further waves of this pandemic, they're going to be much smaller, they're going to be a lot more manageable, and that society as a whole is going to be able to function. So I have a huge amount of optimism in this being very helpful. I want to caution that optimism with the fact that it's going to take time, because the tests that we have right now are not very efficient. Most of the kits can only do one test at a time. So that's not giving you a lot. The other thing is we haven't completely validated the false positive and false negative rates. And that obviously has serious implications for any decisions you're going to make based on a result. So we've got some kinks to work out, but I'm hopeful they will be worked out at some point in the next several weeks.
Thank you very much. I think we'll go on to the next part of these rounds, which is best case practices. And I'd like to introduce someone who needs no introduction, Amandeep Rai, the Associate Program Director, who's going to address the topic of best practices for comprehensive ophthalmologists. Amandeep?
Thank you. I'm just going to get my slides up here. Okay, so thank you, Abdu. We appreciate your time. Maybe we'll get a couple more questions in after my talk, because I don't think I'll be as interesting as you were, and a very tough act to follow. So first of all, I do want to wish happy Passover and Good Friday and Easter to all of our colleagues who are celebrating these holidays. I want to start off by talking about the TORIC course. TORIC is a 6-week course that many ophthalmologists have now been through themselves. It is a national course that brings together every postgraduate year 1 resident from ophthalmology programs across Canada. And it's the culmination of years of hard work from people like David Yan and Yvonne Bies that I now have the pleasure of being the co-director of. This course is something that all of our PGY1s look forward to, but unfortunately, it's become painfully clear that there is no viable path forward for an in-person TORIC course this year that would be responsible or safe for our students or lecturers. And like many of our teachings these days, we are going to convert it to a virtual platform, so the residents will get the academic portion of this. The TORIC course will run from June 1st to 30th with tests administered locally. And that is only a 4-week course. Typically, this is a 6-week course. And the reason we've cut it down is we're hoping to bring the PGY1 residents back to Toronto next year for 2 weeks, where they can do some of the hands-on anatomy wet labs, surgical wet labs, optics teaching, low vision, and things like that. And of course, that allows them to have a somewhat social component too. Abdu, I think you were raising your hand there.
Yeah, I'm really sorry. I've got a slew of consults that my resident has told me are waiting, so I apologize. I'll have to excuse myself. I thank you for the gracious invitation, and I'm more than happy to help out again, or if anybody wants to send me an email with any questions, I'll answer.
Abdu, thank you
for
very
being with us.
much. On behalf of all of us from the University of Toronto and really across the world who are listening in, I want to thank you for your participation, and we look forward to having you join our future panels.
Thanks so much. Happy Passover, Chak Samish, and blessed Easter to everybody.
Thank you. Thank you very much.
So what's old is new again for many of us millennials. We had no idea that our smartphones actually made phone calls. We only use them for text or email or Instagram. But actually, I've been calling patients, and this does help relieve some of their anxieties and does reduce the need for in-person visits. Of course, there are some patients who are still going to require an in-person visit, and I think there's things that you should do as precautions for this. So first of all, in addition to the phone call that they already had, telephone screening is very important. So our staff are asking for, there's a checklist of symptoms that is constantly changing, that they're going through fevers and sick contacts. As some of the speakers have already alluded to, we are keeping our waiting room as empty as possible of both people and furniture. We've put the chairs at least 6 feet apart so that there is no chance of people sitting closer than that. We've put up signs everywhere indicating that we are going to limit speaking during the encounters. What I've been doing is I've been speaking to the patient from the end of the room and maintaining at least a 6-foot distance, allowing them to provide me a history or ask any questions. And then I tell them that during the actual examination, we are not going to be speaking at all. And after that, there will be another opportunity for discussion or questions. I will defer some of these other topics to the other speakers, but we are limiting diagnostic testing. We are asking patients not to arrive too early for their appointments and to leave the office immediately after their appointments. We are also limiting caregivers. So typically, most of our patients will bring another person with them to their ophthalmology office visits, but we are asking them to not do so. If they do have a caregiver, we're asking them to wait in their car, except in extenuating circumstances where someone absolutely needs a caregiver. If someone has a routine visit and it's for something like a prescription renewal, that can easily be handled via fax or over the phone. We are also limiting what we're doing in terms of our actual examination. So of course, we don't need to dilate every patient in the midst of a pandemic, but if we are going to use diagnostic drops, we encourage you to use minims for that to limit cross-contamination. And I know we've got Yvonne Baez on the call, but I don't think we need to check pressure on every patient in this scenario. And if we do, I would recommend that we use a tonal pen to do so. Initially, on the left, what we did is we made a homemade shield. This is not ideal, but it's better than what we had before, which was nothing. Since then, we've had commercial shields installed. If you're in Ontario, on OnTi, there's a great contact that was put out. If you're not in Ontario, feel free to email me and I can give you his contact, and he may know people in your province who can provide you something like this. But these are better shields, mostly because they are much easier to clean, of course, and that is very important. This doesn't reduce the need for other PPE, but certainly is an additional barrier that I think is very useful. For our staff in the clinic, as well as us, what I encourage people to do is to wear scrubs in the office that you put on at the hospital. So make sure you come to work in your street clothes, change into scrubs that you picked up at work, and change out of scrubs before you come home. We're also encouraging surgical masks, as well as goggles and face shields, and gloves. And this is just a reminder that the Toronto Raptors are still NBA champions if the season does not continue. We have put all elective surgeries on hold at this point. So actually, this is where I was going to do a quick poll. And I was going to ask, I hope the poll is up. When was your, if you are somebody who does cataract surgery, when was your last phaco list? I'll give that about 10 more seconds to run, and then I'll share the results with you guys. Okay, so we got some good results there. So the results are encouraging in that nobody has done a routine phaco in the last week. Less than 2% of people had a list within the last 2 weeks. So most of us have shut down within the last 3 or 4 weeks, which I think is excellent because number one, this is in line with our national bodies such as the COS and the American Academy and the Center for Disease Control. And it also has the added benefit of limiting foot traffic through our offices. For surgeons who do cataract surgery, there's a high burden of consults, preoperative visits, and postoperative visits. And canceling surgery also means getting rid of all of these visits, which I think is very, very important in limiting spread. As a general ophthalmologist, a lot of what we do is chronic management of conditions such as AMD and diabetic retinopathy and glaucoma, dry eye. And a lot of these visits can and should be deferred for the time being until it's safe to do so. I think that every patient who has a chronic condition that you bring in is a patient that is potentially being put at risk. Of course, we are still open for emergencies. Despite the COVID pandemic, people will experience vision-threatening emergencies, and we should be available to see these patients and treat these patients, but do so in a very safe manner. And finally, I do want to recognize that, first of all, Dr. Li Wen Liang was a 34-year-old ophthalmologist from Wuhan, who was one of the first people to raise the idea that there was a SARS-like illness spreading. And initially he was ostracized, but he's obviously been right. Unfortunately, he passed away from the COVID pandemic. Our thoughts are with his family, as well as all the healthcare workers across the world who are currently battling this disease. It is very sad what's happening to frontline workers. So with that, that is the end of my slides there.
Amandeep, thank you so much. That was excellent. I think a really nice perspective on what's going on as a best case practice from comprehensive. We're going to move along, and what I'm going to do is, just in case there's redundancy, I mean, I think what we're going to do is just try to add new information as we move forward. So with that, I move to Dr. Yvonne Baez.
Thank you for inviting me. So I'm just waiting for my slides to come up. Unprecedented, challenging, and chaotic are words that we're hearing constantly now. And I think it's amazing that Alan and DOVS team has put together this webinar, and you can see by nearly 450 participants how important it is. We can go to the next slide. We're all looking for information and trying to understand misinformation. And I'd just like to let everyone know that the COS is a good resource for this. On the COS webpage in the bottom right corner, you can click on Resources COVID-19. If you go to my next slide, and that will right away take you to our PRC, Practice Resource Center. This is an online tool that was launched in May of last year, and it provides a lot of educational activities. So you can go through it directly and then click on the link for COVID-19, or you can go to it through the COS site. And I just would like to put up my first question here. So I'd like to know how many of you are aware that the COS had this practice resource center? Yes, and I've accessed it. Yes, but I haven't accessed it. And no.
So about a 50-50 mix there.
Okay. So I've got my work to do here. We do send you regular e-blasts about the tools that we've been developing. And if I can go to the next slide, and you'll see just within the COVID area, these are all the documents that are out there right now. Some of them are produced from the COS, some are produced by our subspecialty societies, like the Canadian Retina Society, the Oculoplastic Society, ACUPO, and there's a new one that will be coming in the next day or so from the Canadian Glaucoma Society. So I would urge you to go to this site to get Made in Canada information that you might find useful. Next slide. So I've been, just again, getting back to information. The problem that we have is a lot of this information you're seeing is conflicting and confusing. So if you like creating documents, I would really encourage you to include all the stakeholders right at the beginning of the development and involve the COS. We have 14 affiliate societies. We can connect you with the appropriate people, and we can also help in disseminating the information to our 1,200 members in both official languages. Next slide. Remember, the COS is the national voice for ophthalmology in Canada. Next slide. So let's now go a little bit more into glaucoma. Starting with this guideline, which was the first one we put out on March 20th, together with the CUPO, on how to examine an ophthalmologic patient, and also it had a section on what are ophthalmologic emergencies. So Amandeep has gone through a lot of this examination portion here. The keys is we still do need to see patients. How do we assess it? Well, we can do telephone assessments to aid in triaging. Specifically in glaucoma, obviously you can't measure the intraocular pressure through the phone. However, you can do assessments on issues with drops. And specifically now, the second biggest crisis I have is drug shortages and discontinuations, which is really a problem in the glaucoma area. And a lot of this you can manage over the phone. Next slide. So Amandeep didn't think tonometry was necessary in everyone. Well, I would say in most people, definitely all of my patients. But as we've already heard, no one should be doing non-contact tonometry at this time. If you're going to use Goldman, which is what I use, it'd be best to use single-use tips, but you can consider the TonoPen or eye care, but you need to make sure you're sufficiently away from the patient. So you would want to definitely have a face shield with those. The use of lenses should only be if they're absolutely necessary, like in acute angle closures, or if you're doing an urgent laser. Visual fields and imaging, other diagnostic tests, I think at this time they're only rarely needed. Next slide. But for all of these, you have to really disinfect your diagnostic equipment between patients. And for tonometry, there have been reports that 70% alcohol and air dry or dilute bleach with wash afterwards are adequate ways of disinfecting. Next slide. So who do we need to see? Well, we need to see our emergent and urgent patients. So the emergencies in glaucoma would be people with symptoms suggestive of acute angle closure, very high intraocular pressures. And we chose this limit of 38 because there you're really getting into risks of vein occlusions. Blebitis or bleb-related endophthalmitis, if you have a device exposure. Urgent and maybe sometimes emergent as well are your bleb leaks and hypotony with vision loss, uncontrolled glaucomas, and people who've had recent glaucoma surgery in the last 3 months. And your threshold for seeing patients might be a little bit lower in the monocular patient. Next slide. In terms of surgeries, those that are urgent surgeries are uncontrolled glaucomas on maximal medical therapy that are progressing, bleb leaks, device exposures, hypotony with hypotenuse maculopathy or large choroidals. When we think of surgery though, we can try to temporize things by using more Diamox or Neptazane, but just remember these are strong medications and you should be monitoring electrolytes. And I think the role of cyclodestructive procedures also can be a little bit extended at this time. And thank you.
Thank you, Yvonne. That was very excellent. A question, do you have, I think I saw somewhere where you sent out a list of drugs that are currently available or will soon come online, various glaucoma drops, because we get calls, and I know all of us have experienced this, where we're getting pharmacies writing us back, this is no longer available, this is no longer available, et cetera, et cetera. Do you have a list of what is available or?
So we did put out that list that was dated March 9th, and I'm going to have it redone because it's a moving target. You can get it through Health Canada. The problem is companies will say the drug is coming now, and then they push the date often. So we're in a really difficult situation because there's basically no topical beta blockers. This is a made in Canada problem. It's not a problem south of the border, which suggests some issues maybe with pricing on the drug benefits that the companies are choosing not to stock Canadian areas. And we are dealing with this with Health Canada. Don't forget compounding companies. Okay, so we should probably be using those more than we are.
Good point. But it'd be nice if you could, you know, once we're looking on the COS website, if we would have that there instead of having to look more than one place. I think it would be good to have that traffic going to the COS. Thank you.
I think it is on the COS website in the Physician Resource Center, cospcr.ca.
Okay, got it. Our next speaker is Dr. Radha Kohli, and Radha is going to talk to us about best practices for medical retina.
Thank you, Alan. I'll try to not be redundant in the interest of time. And all the best practices I'm going to talk about for medical retina are really based on the big associations, the CRS, the ASRS, the AO, and of course the COS. The first thing I want to say is this really is a moving target. So the best practices or approaches that we're using today may change in a month from now, and we may be back here in a month singing a slightly different tune. But for now, for medical retina, we sort of want to follow the principle of postponing all patients that we possibly can and limiting our practice to essential visits only. So routine diabetic checks, plaquenal checks, patients with other maculopathies, inherited retinal diseases, all these types of patients can be safely postponed as they're being monitored, but don't currently require treatment. Now, I'll keep saying this throughout this little part, but communication with our patients is very important. There are patients who come in for routine screening and they get a lot of comfort from this screening, and they may ask to come in despite the office postponing their appointments. And it's important to call these patients and assure them that should they experience any vision changes, that we're here for them, but for now it's safest to postpone their appointment. New patients, patients with acute vision loss, of course, these patients still need to be seen, but it might be worthwhile to call them ahead of time. One, to just let them know that we're following all protocols to minimize their risk of exposure. But also, if a referral is vague, we may want to call patients and actually make sure that they do indeed need to be seen. Patients like little premature babies who require ROP screening and treatment also need to be seen despite the current status of things. And then we have our own patients, those patients who are undergoing panretinal photocoagulation for significant proliferative disease, and patients undergoing intravitreal injections. So there are a cohort of patients who are calling and canceling despite receiving treatment, and that's okay. I think these patients are under a lot of stress and they feel that they have to choose between their vision and their life. And I think if we can go through their charts and call those patients and again tell them that we understand the predicament that they're in and that it's okay to postpone their appointments, but that we're here for them in the event that they do experience vision loss, and to also stress the importance of screening while they've postponed their appointment. Then there are patients who we need to see, and we have to make the decision of whether we can see them now or whether we need to postpone them. And these are really mostly our intravitreal injection patients, and we can somewhat triage these into the main three categories: patients with diabetic macular edema, vein occlusions, and wet age-related macular degeneration. And diabetic patients, I think it's safe to say many of them can be postponed for 1 or 2 visits without incurring irreversible vision loss. Again, this is nuanced. It's not to say that all patients with diabetic macular edema should be postponed. A monocular patient who hovers around driving vision, for instance, may benefit from an injection and may wish to come in so that they can carry on getting their groceries and maintain their activities of daily living. But for the most part, many of our diabetic patients can be extended out 2 to 4 weeks. Similarly, with vein occlusion patients, many of them might be able to be postponed 2 to 4 weeks, or we can keep having them screen themselves and reassess with them over the phone. But again, it's more nuanced. There are some patients who we know have recurrences. Remember, our intravitreal injection patients, we all know them quite well. We've seen them for months or 6-week or 8-week or 12-week intervals for years, and we know the ones that will recur and need treatment. And wet age-related macular degeneration is a little bit more intense. Some of these patients can't be postponed, and they really do need to come in. They can scar, they can have recurrences. So those patients that do need to be seen, we need to assure them again that we're following all the protocols to keep it safe for them, but we do need to see them. And those that can be postponed, maybe they have chronic subretinal fluid and we know that they maintain their vision, we ought to postpone those patients too. I think the key thing is there was a survey by the ASRS, most retina offices in the US at least, and I think from talking to my own colleagues here, have reduced their clinic volumes significantly down to about 25%. And this is very important so that the patients that we do bring in, that they're spaced significantly to maintain social distancing. Of course, all the things that Amandeep and others have recommended, PPE, wiping down surfaces, also have to be followed through with. And then the examination component, again, is quite variable. A patient who we know is going to recur without an injection who comes in but has been a longtime patient who's mostly stable might just come in and get an injection and get no vision, no dilation, no OCT. So that's one end of the continuum. The other end of the continuum is new patients will need a full exam. And then there's something in the middle. If you really want to determine if you can postpone patients. You may come in and have a vision and an OCT so that you can say, okay, your OCT is relatively good and stable, and we can postpone you. Instead of bringing you at 6 weeks, let's try 8 weeks. So the principle is postpone as much as you can and see those who you really only have to see. And on top of this, communication is really important for our retina patients because they are very anxious. They've all experienced vision loss and then have regained their vision, and they really need to know that we're there for them in the event that they do experience vision loss if they decide to defer their appointments. Now, I have to say, from my perspective, it is there's a lot of anxiety around deciding who needs to come in and who doesn't need to come in. We're putting ourselves at risk, our families at risk, patients at risk, and society at risk, and making this decision of, are they going to lose vision or not if I don't treat them versus am I putting them at risk for exposure is significant. So I have a question for all of you in terms of how you all are feeling, for those of you who are seeing patients, not necessarily injections, but any patients, on how your anxiety level is.
Rather, 1 is being very anxious and 5 is not anxious. Is that how you're doing it?
Yes, yes.
Okay. Most are moderately anxious.
Mm-hmm. I mean, we're in a difficult position in all of us who are treating patients in all our specialties of, patients of who we really have to see and the risk we're putting them at and who we can defer. So the anxiety, I think, is a real thing too. Thank you. I'll stop at that.
Thank you, Radha, for sharing those pearls. In the interest, we're running over. In the interest on trying to move this along, we have one last talk. I'm gonna hold my talk for the next time we have these rounds, and I'm gonna ask all the panelists if they'd be kind enough to just stay around a little bit after we finish, so that we can answer all the questions. Our last speaker is going to be Dr. Rob Devigné, and he's going to give us the surgical retina perspective. Rob.
Thanks, everybody. I'll be brief. Most of the points have been discussed. I certainly do echo Radha's comments, though, about how valuable it is to call patients, not only to ease their anxieties, but you can really get an assessment as to who should or shouldn't be seen, who wants to come, who doesn't want to come, even for post-op patients, not only the injection patients. So it really has been something that we've never done before in ophthalmology, but it's been really quite gratifying and helpful. With respect to UHN's surgery, our surgical department, we communicate all the time, and they've been really very aggressive from the outset in terms of limiting things. For the first week after the pandemic was declared, our service had 1 day per week, down from, I don't know, the usual of 10 or 11. But after the first week, all services lost all their elective time, and we have just 2 emergency rooms every day that every surgeon has to compete for. And the rationale for that is obviously not only to minimize the amount of surgery being done, but to minimize the amount of traffic within the hospital and to really only do the things that we need to do. Also at the hospital, every patient who's going to have surgery, other than patients who have to have it done within a few hours, have to have COVID testing, which necessitates a 12 to 24-hour delay. And the COVID negative ones are operated on. If they're COVID positive, then we have to think long and hard as to whether we really need to do it. In surgical retina, we're of course only operating on the most urgent cases, such as macula undetachments, open globes, vitreous hemorrhages in only-eyed patients, etc. The interesting dilemma that, though, it's going to bring is, at the outset, when we started, it was pretty easy to delay surgery. Diabetics and various other retinal surgical entities we could delay for a week, 2 weeks, 3 weeks. But now that we're getting several weeks out with no end in sight, it's going to be more challenging to reevaluate who needs to be operated on and who starts getting into the realm of permanent deleterious effects of prolonged delay. So that's something that we're really going to have to wrestle with. And that's where we are.
Thank you, Rob. I'm not going to repeat what was said already, but for cornea, what we're doing is David and I are alternating days that we're in so that, God forbid, one of us gets sick. There's always cornea care available at Toronto at UHN, and we're never there at the same time. Really, again, Rob, as the hospital came out with, they're just organ or sight or limbs or life-saving operations that are being done. And really in cornea, we've limited to, corneal ulcers, graft rejections, corneal melts with perforation, graft rejection. So I think we've limited it down to a handful of patients that we see, and these patients really need to be seen. I want to wrap this up, and then we will stay around. I'm going to ask all the panelists to please stay for questions. I just want to point out that we had, at our maximum, 450 people attending, which is really a record for Grand Rounds. I'd like to thank our Grand Rounds team, Amandeep, Sharif, John, and special shout out to Sandra Gochi. We hope these Grand Rounds have been informative. Please communicate back to me if you have any comments or topics you'd like to see covered in the future. The University of Toronto Department of Ophthalmology and Vision Sciences will be continuing every Friday with our virtual Grand Rounds. We had Jonathan Biccielli last week speaking on neuro-ophthalmology, which was outstanding. Rounds are 12 noon to 1:15. Amandeep, what's on for next week?
Yeah, actually, I was going to mention next week is a great topic. Panos Christakis will be speaking on plaquenal toxicity. So very timely. Hopefully, maybe we can get the president down south to tune in before he recommends it for everyone prophylactically. In the interest of time, I am going to ask one question here that we have, and this will address to Dr. Aldaffrawi maybe. There's a question that says, with surgery expected to begin resuming in June, for planning purposes and recognizing it's hard to say for sure, is it fair to assume similar timelines for routine clinics in the community?
Yeah, Amandeep, I suspect so. I think we're going to be looking at late June or July. I don't think we're going to be able to go back full bore right away, and I think it's going to be a slow ramp up with precautions in place. But and it's also very hard to predict. There's no crystal ball, but I think that's probably our best guess around that time, starting to ramp up.
Brad, do you see a role for antibody testing here? Again, I know Abdu sort of addressed it. From your perspective, from emergency medicine, what do you see that role in terms of starting to ramp up our clinics, trying to keep our patients well cared for but safe, as well as keeping our faculty, our techs, ourselves, and our families safe?
Yeah, I think, well, this falls sort of outside my area of expertise, obviously, but I think it's too soon to tell. I think right now we stay the course and we continue best practices based on, again, limited case numbers and reports from other places around the world, but we just don't have enough experience in Toronto, not only with our own testing, but with novel tests that are on the pipeline.
Thank you. Any other questions? Amandeep, do you want to take some of the...
There was a number of questions that were for Abdu, so I think there's enough demand that we'll probably have to get him back here in a few weeks and maybe give him some more time. And I do suspect that many things will change in that time. I want to thank everyone who did tune in. It's truly incredible to have so many of our colleagues from across Canada and internationally for these rounds. We will stay on and answer questions for as long as possible, but in recognizing the time as well, we've gone over. I think it's very reasonable to also end our rounds for today, but we'll stay on for additional Q&A. Again, I want to remind everyone that next week's Grand Rounds will be very timely with plaquenal toxicity, and you feel free to invite your colleagues from your centers to join. We will circulate the links once again.
And on behalf of all of us, for everybody still on, wishing you a very happy, healthy, and safe Passover and Easter.
right. So
I think if there are no questions, maybe end this.
there's a couple comments here. Someone's put up a website, drugshortagescanada.ca. This may be relevant for the shortages that we're experiencing. There's a lot of questions around serology testing, so we'll defer that to next time, and hopefully we may even be getting serology testing at that time. And there's questions around N95s. Unfortunately, I think some of the questions around N95s are more at a public health level that we probably won't be able to answer. But of course, I think we all recognize that in an ideal world, we'd have an unlimited supply of these. And there's questions, I think Alan addressed this at the beginning of the session. We have recorded these rounds. I know that some folks couldn't join us due to Passover and Easter. We have recorded these rounds, and we will make them available. I don't know the link yet, but we are working on that. Okay, I think that's it. So maybe Dr. Aldaferrari, if you want to close out our rounds.
Well, I'll say thank you to you, Amandeep, and excuse me, Alan, for an excellent and informative rounds. That was really useful. It would be tremendously useful to get updates, as you mentioned, Amandeep, and maybe depending on what transpires every week or two, if we can have a special COVID rounds to keep us updated with respect to not only what's happening in ophthalmology, but expertise in other areas. To all that those that have joined around the world, in Ontario and in Toronto, thank you for joining. And I wanted to give a special shout out to our residents and all the resident physicians out there and medical students who are really, a lot of them on the front lines, whether it be for ophthalmology or for internal medicine faculty. We have not yet had to be redeployed. But my heart really goes out to our residents who are working hard to see our emergency patients and to see the very sick patients in other areas. Have a great weekend, everyone. Bye-bye.
Thanks, everybody.
Thanks, Sharice.
Take care.
Go to sleep, Wai Ching.